Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is actually a very nice case of a rare tumor entity that occurs in the ovary, which is small cell carcinoma, hypercalcemic type. This is a case of a 22-year-old female patient who presented with pelvic pain and was found to have left-sided pelvic mass. At that time, they were not sure whether this involved the ovary or not. And so excision of the mass was performed, and this is the low power magnification of the mass. And as you can see, there is some nodular growth pattern of cells with some pinkish cytoplasm. On higher power magnification, this is one component of the tumor where you have cells with vesicular nuclei and some small prominent nucleoli, scattered apoptotic figures here and there. But what was really very eye-catching is the presence of rhabdoid cells. And these are cells with vesicular nuclei, very prominent acidophilic nucleolus, and then two eccentric part of the cytoplasm filled up with a globule, acidophilic inclusion within the cytoplasm of the tumor cells that is displacing the nucleus to one side. And this is the typical rhabdoid appearance to the tumor cells that was originally described, whether this was in the kidney rhabdoid tumors, in the ovary, or even in the brain in the atypical teratoid rhabdoid tumor. And again, another focus where you have this nodule with the tumor cells showing this vesicular nucleus, very prominent acidophilic nucleolus, and then this globule in the cytoplasm that is acidophilic and pushing the nucleus to one side, giving this appearance that is reminiscent of rhabdomyoblast, but in reality these are not this hence the name rhabdoid tumor. And this is just to contrast, this is the small cell component, the usual small cell component of the tumor, where you have some vesicular nuclei, inconspicuous nucleoli without really abundance of cytoplasm. But as you can see, the background is somehow myxoidish versus the typical rhabdoid morphology, where you have the cell with the vesicular nucleus, the prominent nucleolus, and then the globule, the acidophilic globule in the cytoplasm. And sometimes it impinges on the nucleus, indenting the nucleus, as in this beautiful example. Again, some myxoidish appearance to the background, and the rhabdoid appearance of the tumor cells in yet another focus. And again, the myxoidish appearance, so that it was like alternating between those areas where we have the myxoid background, where we have the small cell component, versus the rhabdoid cell component. And again, here where we have the myxoidish background, but this time containing the rhabdoid cells. Now, importantly, in one of the sections, this is part of the fallopian tube, and then the tumor cells are just growing beneath the fallopian tube. And this was an important clue to the diagnosis, in addition to the rhabdoid morphology of the tumor. And of course, when you think about rhabdoid tumors of the ovary, you have always to think about the small cell carcinoma, hypercalcemic type. And the first thing that you would do is the SMARC-A4 or the BRG1 immunohistochemistry, because typically these show loss of the nuclear stain in the tumor cell nuclei in comparison to the positive internal control. So these are like the SMARC-A4 is similar to the SMARC-B1 or the INI-1 immunohistochemistry. This is another component of the family of proteins, which when knocked down, which when mutant, will result in loss of the nuclear stain. Now, the loss of a nuclear stain, this is from the fallopian tube. This is the lining of the fallopian tube, and this is the tumor growing beneath the fallopian tube, and this is on higher power magnification. Now, remember that the classical teaching is that you have to see total loss of the nuclear stain in the tumor cell nuclei nuclei in comparison or compared to the positive internal control, for example, the fallopian tube lining. However, some articles really describe attenuated staining pattern rather than the complete loss of the staining, which is still an acceptable criteria to support the diagnosis of this type of tumor. Now, importantly, and especially in the presence of the rhabdoid cells, which are also called the large cell component of small cell carcinoma of the ovary, you will see positivity with EMA, with again highlighting the globular cytoplasmic inclusion, really very helpful to support the diagnosis, as is the case with the CD10, showing again this globular positivity in the cytoplasm of the tumor cells supporting the diagnosis. WT1 shows a nuclear staining in the tumor cells. Calretinin is described to be positive in some of the tumors. In this particular tumor, it was only focally positive. Now, importantly, cytokeratin MNF was completely negative. Remember that the EMA was positive, so you might think that this is perhaps a kind of undifferentiated carcinoma, but cytokeratin is typically negative in this type of tumor, and this is the fallopian tube lining. Desmin is negative, and it's important actually to do Desmin because you do not want to miss a rhabdomyosarcoma occurring within the female genital tract, especially with the young patient age. So Desmin is a must to do in order to rule out rhabdomyosarcoma. Inhibin was also completely negative, and because of the age of the patient and the location of the tumor, you don't also want to miss diagnosis of a germ cell tumor, so SAL4 was completely negative. Now, this is the other SMARC family of proteins, the SMARCB1 or the INI1, which is retained in this tumor. Remember that the SMARCB1 and the SMARCA4 are mutually exclusive, so you have a loss of either of the stains. You don't have loss of both nuclear staining. So the final diagnosis of this case was an ovarian small cell carcinoma hypercalcemic type. Now, I should mention that the patient did not have hypercalcemia, which we asked for to be tested once we made the diagnosis. However, hypercalcemia is only seen in about 2/3 of cases. It's not a mandate for the diagnosis, despite of the name of the tumor. Remember that whenever you see a tumor with a rhabdoid look in the pelvis, you have always to rule out, especially in females, of course, ovarian small cell carcinoma, the hypercalcemic type. Remember that rhabdomyosarcoma enters also into the differential diagnosis, so Desmin and plus minus myogenin needs to be done. And remember that you have always to rule out germ cell tumors regardless of the morphology, because germ cell tumors are amenable to treatment and actually to cure, versus the poor prognosis that is associated with the small cell carcinoma of the ovary. I hope you find this tip useful in your daily practice. Thank you.